Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good day. I'm Dr. Rozanizam Zakaria, psychiatrist from IIUM. So today I'll be recording a lecture entitled Dissociative Disorder. This is meant for one of the topics under Introduction to Psychiatry for Year 4 MBBS student IIUM. However, I will also upload the topics into my YouTube channel. Hopefully it will benefit others as well in case there are people who are interested in this topic or students from other universities who are interested in looking into or getting to know more about this topic. So I'll be presenting using my slide, and some of the slide that I use is taken from a presentation from previous students, including my personal lecture notes. Some are taken from resources available on YouTube on a similar topic. Let me just start by showing the slide. So for my year 4 student, this will be an overview of the topic. We will discuss any queries during the actual session, inshallah. Okay. So whenever we talk about dissociative disorder, some might not have much clue about what dissociative disorder is, but one of the things or one of the common topics or things that we normally discuss along dissociative disorder is dissociative identity disorder, which is probably one of the most portrayed mental illness in the media, in particular in Hollywood. For example, one of the recent one is a movie called Split. So some of you might have had chance to watch the movie. Those who have not seen the movie, in essence, is about a person by the name of Kevin who had history of being abused by his mother and then left by his father, and resulting from that, he had a condition called dissociative identity disorder. And throughout the movie, he was described as somebody who's undergoing psychotherapy with a therapist. And along the way, they describe 23 distinct personalities that occur within Kevin. And in the movie itself, of course, they add the dramatic components to it to talk about identity which fighting among each other, and how this alter the whole Kevin's life to some extent. So what we'll do today is, apart from discussing about dissociative disorders, we'll also hopefully will be able to demystify dissociative identity disorder or dissociative disorder in general, as opposed to what has been outlined or showed or portrayed within media. So we probably will be able to tell which one of it is true, which one is possibly is just a dramatic version of what the real disorder is all about. So we'll be talking about main three diagnosis under dissociative disorder according to DSM-5, but we'll be also touch briefly about some of the principles behind it, management, as well as other unspecified disorder that is also included in DSM-5, inshallah. Okay, now some of you, if not most, would probably have an experience of driving a car. Now, if you are an expert driver, you may have noticed that at some point in your life while driving, you notice that you can almost do the driving in an automatic mode. What I mean by automatic mode is you can do every single action during driving without actually put a lot of conscious on doing it. And maybe you will realize that sampai dah, and suddenly you are there without realizing what actually happened seconds by seconds or minutes by minutes during the driving process. Or another common example is when you're praying. So because we are an expert prayer, and in the sense that we've been praying probably for most of our lifetime, we are able to complete the prayer without realizing what we've done. So basically dalam bahasa mudahnya kita jadi tak khusyuk. Tapi badan kita actually doing every single step of it without us having to remind ourselves on apa ni rukuk, apa ni sujud, sujud baca ni, tidak baca ni. We don't have to remind ourselves because it's almost done automatically. Now, we call it autopilot, but in essence, it's actually a snapshot of what dissociation is all about, in which we are able to be in a state where we are disconnected from what is actually going on. But this is not a pathological dissociation. We call this normal dissociation because most of us can snap out of it. And more importantly, it is not something that is harmful or distressing or having or something that may cause any painful consequences to our either physical, emotional, psychological well-being. It is something that occur on daily basis. So we don't call it pathological dissociation. However, for some people, the feeling of disconnected can become intense and often to the point where it affects their daily function. And the impairment of awareness too can occur in the form of impairment of awareness of action, thoughts, physical sensation, and identity. So collectively, we call this dissociative disorder. It has a strong connection with trauma, especially early child abuse or neglect, and the beginning of development of this pathological process is what we call a defense mechanism. So some of you might have already come across defense mechanism from other lectures. And just to remind, it's actually an involuntary and unconscious process that occur within our mind, which is designed specifically in order to cope with any distress situation. So the function of coping mechanism, the function of defense mechanism is almost equivalent to a homeostasis process within our body physiologically. So it is a process that aims to correct the imbalance that happens within us. For example, you are a calm person, you have no problem, but suddenly a friend of yours came to see you and break a very bad news to you. Let's say something about you failing the year, for example, or you lost a great friend, for example. So this particular incident will disrupt the stability of your emotion and psychological well-being that you had initially. So in order to regain the stability, our subconscious mind will do a specific way, will create a specific way to balance it out. So unconscious effort to balance it out is what we call a defense mechanism. For example, somebody may become denial and say, yeah, no, you are lying to me. What you're telling is not true. It can be. I just met my friend just now. How can he pass away? So the denial itself is basically a way that you will not become severely shocked by the news. Right, so that's an example. And one of the example of defense mechanism is dissociation. So I normally give an example if you want to imagine or picture it more easily, is when you watch a lizard, cicak lizard, and when you watch a lizard get attacked by any form of danger. So one way that the lizard will defend themselves is by splitting its tail from its body. So it dissociates its tail from its body. So that's essentially what happened in dissociation. in defense mechanism. So you dissociate something in order to save yourself from a danger. But of course, as a human, we cannot dissociate any parts of our body. That's impossible to happen. So what do we dissociate? So we dissociate our thoughts, our emotions, our sensations, our identity, our actions in order to maintain the crisis that occur. So that's the fundamental of it. So to understand dissociative disorder, you have to understand dissociation. So as I mentioned, it is an unconscious defense in which we segregate any group of behavior or mental process from the rest of our our body. It involves the mechanism so that there is a discontinuation of one or more mental function, either memory, identity, perception, consciousness, or motor behavior, in order to regain the stability. So this disturbance, the dissociation can occur sudden, gradual, temporarily, or persistent. It normally connected closely with psychological trauma. Now, this is a graphical representation of what I've already mentioned. So if you can imagine, our self is composed of this part with our body, our identity, our memory, our perception, our consciousness, which is influenced by internal factors and external factors. So all of this connected into one and make who we are. It may sound rather philosophical, but if you understand about it, every single of you have your own identity, your own memory, your own perception, your own perception. So yet that's who you are as a person. Now, what happened when somebody experienced trauma? So one of the things that will occur is they will dissociate themselves from one or two components of their self in order to defend themselves from the crisis or from the trauma that they had. So depending on which part of self that they are disconnected to, it becomes a disorder. For example, if they are disconnected to their identity, so it is essentially a form of dissociative identity disorder. If they are being dissociated by memory, we call it dissociative amnesia. If they are dissociated from their perception, we call it depersonalization or derealization. So we'll be talking about the specific disorder in a short while, but this is a graphical representation of what I've been talking about in the beginning of this talk. According to DSM-5, there are basically three main dissociative disorders, which is dissociative identity disorder, dissociative amnesia, and depersonalization derealization disorder. And then there is dissociative fugue, which is basically an extension of dissociative amnesia, and there's also other unspecified dissociative disorder. Now, you don't have, for year 4, you don't have to worry too much about the details of every single dissociative disorder, but just have an idea. The idea of this lecture is to have an idea about what does it mean by dissociative identity disorder, what does it mean by dissociative amnesia, and then towards the end, we'll have a general idea about how do we manage such condition in a general term. It is, to be honest, a very one of the rare conditions that occur from psychiatric point of view. And myself, 10 years of the experience of working under psychiatry, I probably had 1 or 2 cases of dissociative disorder that I see in my practice. And majority of dissociative symptoms that occur normally are the results of other diagnoses. So you might still see dissociation in depression, PTSD, panic disorder, but to see a case of pure dissociative disorder is actually very, very rare. All right, the first one is dissociative identity disorder. So just have a look at DSM-5 criteria. You don't have to remember every single thing of it. You just have to remember the essence of it. So the essence number 1 is it occurs in the form of disruption of identity. So identity is who we are as a person. It is disrupted in which the person will develop another 2 or more distinct personality states. So for example, the the original version of that identity is somebody called Ahmad, then Ahmad may have another one person, which is a younger Ahmad. Another person is a female version of Ahmad, which is maybe Siti, and then another fearful or angry or brutal or aggressive form of Ahmad, which is actually another person by the name of X, Y, or Z, which may relate to somebody in his life or may not. So the first criteria is the person developed at least another 2 or more distinct personality states. Now, the disruption will involve a marked discontinuity in sense of self and sense of agency. That means when Ahmad becomes Siti, so Siti has nothing to do with Ahmad. So Siti has its discrete personality. So Siti has different things that she likes, different way of addressing herself, different way of connecting with people as compared to Ahmad. So that's what it means by a discontinuity in a sense of self, accompanied by related alteration in affect, behavior, consciousness, memory, perception. So basically, once Ahmad becomes Siti, every single part of Ahmad now is gone. So everything else about Ahmad is now become everything else of Siti. What Ahmad likes when he is Ahmad is no longer what Ahmad likes when he is Siti. So that's what basically the diagnostic criteria is saying. So the signs may be observed by others or reported by the individual. So it is not uncommon to see that somebody reported that I have another identity, but it's also possible that the individual has not realized it, but other people described it. At times you were talking like a child. Do you know that happened to you? So that's probably an example where the symptoms is being reported by other people. And B is basically the consequences of disruption in identity. There's a recurrent gaps in recall of everyday events or important personal information or traumatic events as a result of the person's changing his or her identity. C, the symptom cause clinically significant distress. So this is the function part of it. And the disturbance is not a normal part of broadly accepted cultural or religious practice. Now, the clause here is important because there are certain cultures where, for whatever reason, there is a situation where somebody may dissociate into somebody else. Now, it may not something that we hear on daily basis, but those who may have seen a movie or documentary about Mak Yung, for example, Menorah, for example, these are apa kita panggil macam traditional performance or activities or rituals that they do. Sometimes bila dia naik sheh betul-betul tu, and the person tu dia just change dia punya personality. So tiba-tiba dia jadi macam watak yang berlaku tu. So even though there is a change of personality in that particular incident, tapi given that it occurred in a certain cultural situation, so we cannot diagnose the person as having dissociative identity disorder. And most importantly is dissociative identity disorder is a diagnosis of exclusion, which basically means that whenever you get a case that you suspect has element of dissociation or dissociative identity in it, now your number one rule is to find other causes until proven otherwise. So things like the physiological effect of substance. So somebody who intoxicated claim that he's somebody else. So you cannot say that it's a dissociative identity disorder because the dissociation, the so-called dissociation, occur secondary to intoxication. Or there is also medical condition that can give rise to dissociation. For example, in temporal lobe epilepsy, for example, people can get complex muscle seizures, and during that time, he's become confused to the point that he is not aware of himself. So he may adopt whatever statement saying that he is X instead of Y, so that is not something that we consider as a form of dissociative identity disorder. So if you think about it, psychiatry itself is a diagnosis of exclusion basis. Dissociative identity disorder is exclusion of exclusion. So it's important that we see um, other possibilities before we conclude that it is dissociative identity disorder. So one of the reasons is because it may mimic a lot of other presentation, and second, that it's very rare. So we need to find something that is more common, more relatable with the context of the patient, rather than pointing it out to one specific disorder that is not common. All right. Now, we don't have much data on GID, but what's known from overseas study is female to male ratio is 5 to 1 to 9 to 1. That means there are more female reported to have GID compared to male. It is strongly related to early childhood trauma. More than 85% to 97% of patients have experience of trauma in life, in particular sexual related and physical related. However, with regards to genetic factors, we have not found out any study that has shown a rather strong genetic relationship between the ID and genetic factor. It's important to note that this emotion impulses is often frequently reported as ego dystonic and puzzling, which basically means they don't like it. So ego dystonic is a fancy way in psychology to say something that you don't like. So if you like it, it is ego syntonic. It goes along with your um, needs and wants. But in ego dystonic, that means whatever that occurs is something that you don't like, you don't want to happen. And it's puzzling. For example, if you are Ahmad, like I mentioned just now, to have somebody else to be inside you, or to hear that somebody reported that there were times where you are not yourself, you become somebody else, is puzzling. So the shift between one identity to another identity can occur rapidly and unpredictably. Individuals may report that their body feels different, um, and it can also be associated with changes in emotions and feelings. Right. Now, it's important to highlight that even though we don't directly ask dissociative identity disorder in our general psychiatric clerking, you don't ask it in when assessing patient with depression, anxiety, for example. But if you do come across symptoms suggestive of characteristic described in the DSM criteria of DID, then we have to inquire about it during our clerking. So these are some of the examples from Kaplan about what we can ask in order to gain information to diagnose dissociative identity disorder. Now, remember to highlight about, remember to take note about other differential diagnoses that you need to consider before you were saying that this is DID. So, for example, schizophrenia, bipolar with rapid cycling, PTSD, borderline, seizures disorder, substance use practitioners are all common presentations that may have elements of dissociation within it. So the distinguished features is something that we'll discuss in the class, but you have to remember that in order to diagnose somebody with um, DID, you have to have a look at other associated symptoms as well. If patients presented with delusion, for example, then you need to think of along the line of psychotic symptoms rather than DID alone. If patient presented with mood changes that fulfill mania, for example, then of course we need to consider bipolar disorder before going to DID per se. Now, prognosis, poor in comorbid organic mental disorder, psychotic disorder, if they have associated comorbidity, then they have poor prognosis. And if they have involvement with substance or even eating disorder, they may have even poorer prognosis. And because we don't know much about it, there is a possibility that these patients end up not having proper assessment, and as a result of what happened to them, they may end up, for example, die of suicide. But because we don't know about the underlying factors behind it, then we don't know the actual diagnosis when they are alive. There's also studies looking into the association of PID and crime-related behavior, and this may be another thing that basically explain some of the behavior related to DID. Hold on a second. Okay, all right. So that's about dissociative identity disorder. The second one that we'll go through is dissociative amnesia. All right, now for dissociative amnesia, we'll still talk about dissociation, but this time in particular, we are looking into one specific element of self, which is our memory. The diagnostic criteria to diagnose dissociative amnesia is number one is an inability to record important autobiographical information. So autobiographical information is the stories about us, our own personal history, usually of a traumatic or stressful nature that is inconsistent with ordinary faculty. So that means something happened to the person, and since the event occurred, the patients have uh, inability to recall certain parts of the event or incidents related to himself. So this is one criteria. B, the losing of memory causes significant distress. Now, it sounds like very trivial. Somebody who has accident, for example, may forget because of the PTSD symptom, or may forget because of the traumatic brain injury. So that's why in diagnostic criteria C, it specifies it it is being stated clearly that the disturbance must not be attributable to the physiological effects of substance or neurological or medical condition or sequelae of closed head injury. So therefore, if everything else has been excluded, but the person still experienced amnesia, then there is a possibility that the person experienced what we call a dissociative amnesia. So at the same time, you also need to rule out other psychiatric problems that may also have element or component of memory impairment. For example, post-traumatic stress disorder, apart from the flashback, apart from the avoidance, they may also have problems in remembering things that happened as a way of them avoiding the traumatic memory of the traumatic event. So we don't call that the dissociative amnesia, we call it PTSD then. Or for another example, is somebody at the 60s suddenly forget about things in life, then given the age, what's more appropriate is dementia or major neurocognitive disorder. So if you think about it, it's actually very difficult to diagnose somebody with dissociative amnesia. You have to carefully dissect the history and make sure that there's nothing else apart from amnesia alone. Okay, now approximately 6% of the population have this condition, according to overseas study. Uh, uh, Different to dif- uh, as compared to DID, dissociative amnesia has equal gender distribution, but it begins normally in late adolescence and early adulthood. So the reason behind it is complex, but one of the suggestions about the etiology of dissociative amnesia is number one, it occurs as a result of extreme intrapsychic conflict. So the amnesia is actually part of the defense mechanism. And second is it relates back to traumatic event that happened to them. Now, there are different types of amnesia. Somebody may forget everything about himself or herself. Some may only forget about selected things in their life. Some may have only certain parts or certain themes of things in life that they forget. So you don't have to remember all of the different types of amnesia, but what this slide is expected to highlight is the amnesia is heterogeneous. So different people will experience, different person will experience different form of amnesia. Now, classical presentation is when somebody presented with symptoms suggestive of psychiatric related problem, and then later we found that the patient also had traumatic life history. Then normally that's how we eventually find that the patient actually have dissociative amnesia. However, there's also non-classical presentation in which they come with some other things. They come with substance abuse, in which the abuse of substance is actually the way that they uh, they the way they correct or self-treat their dissociative distress from dissociation. Somebody presented with self-harming behavior, suicidal behavior, violent outbursts, interpersonal problems. So they don't come to see doctors for dissociative amnesia or dissociative identity disorder. They come for other reasons, but once we get to the root of the problem, we may find out actually there's element of dissociative. Now, this is a point about associative features to support the diagnosis. You don't have to go through in details about this, but you can read it for more understanding later. Again, remember about differential diagnosis. Look into other possibilities before we conclude that the person experiences associative amnesia. Now, cause and prognosis is resolved normally once the person is removed from the danger or from the traumatic experience. However, some develop chronic forms of generalized, continuous, or severe localized amnesia. Some may actually disturbed by it to the point where they can no longer function normally as before. Now, on top of dissociative amnesia, some may actually develop what we call a dissociative fugue. Fugue basically means developing another way of life. So it is a sudden unexpected travel away from home or one's customary place of work with an ability to recall one's past. So for example, somebody had traumatic experience, developed dissociative amnesia. So he is previously a teacher, for example. During the amnesia, he become he travel away, and as a result of losing his previous memory, instead of going back to school and becoming a teacher, he stopped at possibly one place and adopt a lifestyle of a villager or farmer or fisherman, for example. So that's an example of dissociative fugue. Because they're confused about their personal identity, the prior identity, they assume a new identity. And this is in itself provide a significant distress and pain to them. So that in essence what dissociative fugue is. Now, one of the last main diagnostic diagnosis that is included under dissociative disorder is what we call the depersonalization and derealization disorder. Now, you have to differentiate between depersonalization and derealization as a symptom and depersonalization and derealization as a disorder. Now, depersonalization and derealization is a psychopathology that can occur in various forms of diagnosis. In schizophrenia, for example, you may see derealization, and the most common one is panic attack somebody may have derealization. They feel like they are in a dream. They feel like their body is changing in some way. But given the context of the psychopathology is panic-like symptom and fulfill panic disorder, so we do not call it depersonalization, nor we call it derealization disorder. However, there is a specific condition in which the person only develop this particular psychopathology, that is depersonalization or derealization, or combination of depersonalization and derealization disorder. So in the context of the absence of other symptoms, so we name it depersonalization and derealization. So don't get yourself confused, just understand the concept behind it. Now, just to recap about what depersonalization and derealization disorder is. So depersonalization is when the person experiences a persistent, recurrent feeling of detached or estranged from oneself. While derealization is the feelings of unreality or being detached from one's environment. So to understand it simply, in depersonalization, the changes is ourself. What changes, apa yang berubah, apa yang terganggu, apa yang disturb is ourself. It may be our body, it may be our self, it may be our hand, maybe our physical, whatever that is, the changes is us. But in derealization, what changes is the environment. So that means the person remain as that person, but the person felt like the environment has changed. Bumi ni terawang-awang, sekeliling macam dalam dunia kartun, ataupun everything else is taller, is getting tall or changes in colors. So that's environment. So we call it derealization. The environment become unreal, not what we used to know or experience. Now, some may wonder how do we differentiate that from perceptual disturbance in the form of hallucination. Now, in depersonalization and derealization, the reality testing is intact, which basically means the person know that what they experience is abnormal, but they still experience it as if it's real. So that's why normally patient will describe it with as if quality. So in Malay they will say, rasa macam dalam mimpi. Tapi saya tahu saya tak tidur pun. Tapi memang betul-betul rasa macam dalam mimpi. So they can describe it as if seolah-olah that's what it is. But they know it is not what it is. While in psychotic disorder or in psychotic symptoms, the patient has no insight, whereby they believe that what they experience is real. So you wouldn't see or hear patient with psychotic symptoms say that saya dengar suara cakap, seolah-olah ada orang sebelah saya. Saya tahu tak ada orang, tapi dia ada kat situ. So that's not normally what patient with psychotic would say, because to them, what they experience is real. We are the one that yang tidak boleh appreciate it because we haven't experienced it. But in dissociative and depersonalization, they experience it, but they know it's real. They know that it's unreal. So when patient had one or two of these symptoms, and the symptom cause significant distress, and it is not attributable by other conditions, then only we call it depersonalization and derealization. And if you look at condition B in the criteria, it specifically say what I highlighted before. Reality testing must remain intact. That means they're not psychotic. If they're psychotic, then you look for psychotic-related disorder punya diagnosis. Now, again, in this condition has more women represented more than men, occur late adolescent to early adulthood, and it is common associated with other conditions. For example, traumatic head injury medical condition and substance use. Now, the theory is number one, some people highlighted about psychodynamic part of it, the defense mechanism that we highlighted before. Somebody related to the stress of experiencing traumatic event, and some related to the neurobiological theories, especially when somebody is taking substance and experience such symptom, and then they can extrapolate from there. I mean, if the substance caused these chemical changes within the brain, therefore the theory of deregulation is resulting from depletion of certain chemicals in the brain. Now, we've highlighted about this before, and differential diagnosis, again, look through organic causes, exclude drug-related causes, and exclude psychiatric illness before you conclude that it is a dissociative disorder. Now, so that's the majority of dissociative disorder presentation that we've highlighted in the 3 forms of dissociative disorder. Now let's talk about how do we manage them. Now, principles behind it is simple. Number one is, first, again and again, exclude other differential. Second, explore if there's a comorbidity. Third, manage risk. So if they're suicidal, they're homicidal, these are the things that we need to integrate within our management. And of course, we cannot simply treat them by single appointment, and they need long-term engagement. And one of the reasons is because normally they have experienced a traumatic event for a long period of time, and the problem has been going on for some time. So we need to have a proper long-term therapeutic relationship with the patient in order to instill treatment or therapeutic effect. And of course, treating is based on what we always emphasize, biopsychosocial and spiritual model. So how do we manage? So first is complete your investigation. Make sure that you've done related biological investigation, psychological and social investigation, as well as spiritual assessment. Now, management can be looked at 3 points of view. Number one is medication. And of course, there is no first-line treatment to treat dissociative disorders. But what we do have is treating the symptoms that are associated with dissociative disorder that can be treated with biological treatment. For example, somebody with dissociative amnesia may experience depressed mood. As a result of that, then we can use antidepressant. Or they become agitated because of the identity that alteration that occurred to them, then we may use benzodiazepine or SSRI to manage the agitation, or antidepressant to manage. Psychotherapy is the first-line treatment. So we have psychodynamic, CBT, grief work, hypnotherapy, supportive therapy, and of course, stress management. We'll go through in details about the psychotherapy in order for us to understand about how we can provide therapeutic support for this patient. And of course, spiritual, from the point of view spiritual, we need to deal with the spiritual issues and challenges related to that. Now, if you look at DSM-5, there are a segment for specific other diagnosis in dissociative disorder. You don't have to worry about this. Let's just go through it quickly so that you understand. Normally, we use other specified dissociative disorder in a few contexts. Number one is if there's a chronic and recurrent syndrome of mixed dissociative symptoms. Sometimes there's identity disorder, sometimes there's a amnesia, sometimes there's a fugue, sometimes there's a depersonalization, derealization, and we cannot tie it down to one. So we call other specified dissociative disorder. Or sometimes it occurs in a very specific condition. For example, somebody who has been tortured under imprisonment, for example. So we use this term as well. Or something that occurs along the line of acute reaction to stressful event, but it occurs very briefly to the point where we cannot justify another diagnosis other than something that related to acute stress reaction. So we call it other specific dissociative disorder. Now, you may have at this point been thinking about how about somebody yang kena rasuk, tiba-tiba menjerit, cakap macam bahasa orang kata macam suara jin, suara lelaki, garau dan sebagainya. So, of course, we do not have jin possession under DSM-5. But what do you see and what do you describe in those situations? If you use DSM-5 to describe them, I think the best diagnostic label that we can use is dissociative trance, and which basically a condition characterized by an acute narrowing or complete loss of awareness of immediate surrounding that manifests as profound unresponsiveness or insensitivity to external stimuli. And it may occur with some stereotype behavior that you see in orang yang been possessed, for example. So, so that in essence is what you need to know about dissociative disorder. Alright, so for year 4, you don't have to worry so much about stop this. Right. So don't worry so much about the details of it. Just try to understand the basic concept behind it. So if I may recap, first is understand the concept of defense mechanism. Second, understand the concept of dissociation as a way of somebody balancing or coping with psychological trauma. Now, the third is dissociation can occur in various forms, and specific form will give rise to a specific diagnosis: identity, amnesia, depersonalization, realization. However, the principle behind it is you must exclude other conditions first. So it may occur as a result of medical condition, for example. It may occur as a result of substance use. It may actually be a part or component of other psychiatric diagnoses. So in those situations, you should not diagnose the person as having dissociative disorders. The dissociative disorder is diagnosis by exclusion. With regards to management, the essence of management is actually to heal the psychological trauma. So that's why the first line is psychotherapy in the form of either psychodynamic psychotherapy, hypnotherapy, CBT, group therapy, or supportive psychotherapy. And however, as a result of dissociative disorder itself, they may experience a particular symptoms that worth treating with biological treatment. For example, depressed mode, anxiety symptoms. So therefore, biological component also will need to be looked at. So that is, in essence, the aim of treatment of dissociative disorder. So these are the major things that you have to understand under this topic. So inshallah, we'll discuss further during the class later. I will share my slides with class representative. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh, and have a very good day, inshallah.